It's kind of an assault on the system, the mother system and the baby system, to give them 50 grams of glucose when that's not what they normally do.
Hello, and welcome back to another episode of the Birth Lounge podcast. All right, you guys, one of the most requested topics from y'all, from our audience, from our listeners, from our community is gestational diabetes. Yep, you guys all want to know, what is gestational diabetes? What do you need to know about testing, and why do we even test for gestational diabetes? Plus, is it safe to decline testing altogether? Well, luckily for you, that's exactly what today's episode is all about. I'm so blessed and honored to be being joined by my friend and someone I dearly look up to, Melissa Chappell, who is a midwife in Utah, and she is the owner of Utah Birth Suites and the founder of Songbird Maternity. She's also a doula trainer of over 22 years. I'm so drawn to Melissa because she is passionate about women's health from a truly holistic standpoint. She really advocates for women's health and their wellness in all areas of their life, rather than the traditional siloed view that we typically get in the healthcare setting. One of the things you're never going to catch Melissa saying is you have to do this or you can't do that, because she truly is an advocate for informed consent and patient autonomy. I know you're not surprised, because that's basically all of the guests that I have on this show. So today we're going to be diving into Gestational Diabetes Mellitus, which is in short GDM, or that's probably how you're going to see it in your medical records and possibly hear your provider refer to it as. We are going to talk about what is gestational diabetes, how do you get it, how often does it occur, who's impacted by it, and what does your placenta have to do with gestational diabetes. Melissa's going to explain why we want to test for gestational diabetes and what's the point of challenging our blood sugar with such a high dose of glucose when in reality, most of us aren't really consuming that much sugar on a daily basis. We're also going to talk about when it's most appropriate to test, what diet and exercise has to do with everything, plus all of the alternatives like fresh tests, continuous glucose monitoring, jelly beans, fruit juice, and a big midwife's breakfast. Plus, is there any harm in just monitoring your regular diet and how your blood sugar responds to that? Are you supposed to fast before your glucola test? What happens if you fail the first one? What does that even mean? How does gestational diabetes impact your baby, and what kind of risk are you assuming for that? Something that a lot of people probably know about gestational diabetes is that you have a higher likelihood of having a quote-unquote big baby, but how much of an increased likelihood? And how does having GDM in pregnancy impact your baby's blood sugar postpartum? And then finally, this is probably the number one topic you guys have requested, but we're going to dive into, if you have gestational diabetes, do you have to be induced? And should shoulder dystocia really be a fear of yours? I'm so stoked for this conversation. Not only is it something that you all are so eager to hear, it's something that I feel so passionate about, And I feel honored to have Melissa on the show because she's so evidence based. She presents things in such a not scary way that you're going to walk away from today's episode feeling informed, empowered, and confident to take on these conversations with your provider at your next visit. Without further ado, Melissa, welcome back to the show.
Hi, HeHe. I'm so glad to be back on.
It's so nice to have you on. And when we first hopped on the call, I told you, like, I miss you. And I genuinely do. Just
Oh, you're
miss
so
your energy. I miss you. I love seeing your face come across my screen. And it's like
Oh,
such an honor and joy to have you back on the show.
thank you so much. You're so sweet. Yeah, it is an honor for me as well.
Oh my
I
gosh.
feel really excited to be on today.
Yeah. And today's topic is one I think that a lot of people have a ton of questions about. Online, there can be a lot of misinformation. In the medical system, there can be a lot of stonewalling, gaslighting, just
Mhm.
simply refusing to get into conversation and talk about options by the medical community. And so, as we started to get requests for this conversation, I knew instantly, ding, 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 I got to have Melissa on the show. I mean,
Oh my gosh.
I knew instantly. I was like, I've got to have her on the show because not only are you evidence-based, which I love about you, but you're flexible and you're open to conversation and you present things in a way that says, here are your options, here are the risks and the benefits, here are the alternatives. What do you want to do? And that is totally my style. So I'm excited to have this conversation today.
Yeah, I'm very much that way. Sometimes people say, "Well, tell me what to do." And I say, "Nope, this isn't my body. This isn't my baby. I'm sorry.
Can't do
I can
that.
keep giving you information, keep asking me questions, but this is ultimately your decision."
Yeah, the worst question for me is, well, HeHe, what would you do? And up until
Yeah.
this point, I had the excuse of, well, I've never had a baby before. I've never been pregnant, which I don't know. And now I am going to have to change my tune a little bit and just say, like, this is not my decision to make. This is for you
Yeah.
to make. And I trust you. And I think that's what a lot of women miss is trust in themselves. And so if their providers and their care team and their doulas and their midwives will not only trust them, but instill that trust back into them. Oh my
Yeah.
God, to watch those women light up and just be
Yeah.
empowered, it is like the sweetest moments for me.
Yeah, it is. Yeah. I think when one of the things that I say all the time, and so you might have already heard me say this before, is that I am a professional who's been doing this for a long, long, long time. A long time. I attended my first birth as a doula when my daughter, who is now 28, was 5 months old.
Oh my
So,
gosh.
so for about 28 years, I've been attending births, and I never, even with all that knowledge and experience, I will never know a woman's body better than she does.
No.
And I will never be able to tap into her intuition like she does, and her inner strength. So, yeah, women know
Right, well,
more.
that's the end of the episode. That's
Yeah.
where we stop. That's all we had to say in today's episode. No, I'm just
Yeah.
kidding. Okay, well, I guess let's dive in. Let's talk about the very basis. What is gestational diabetes and why does it happen to us?
So a lot of people don't realize this, but pregnancy is an insulin resistant state. So when you're pregnant, your body is a little bit insulin resistant, and the reason why is because the baby needs glucose to grow. It's really important for a baby to have glucose to grow. So we're already in an insulin resistant state, and diabetes is when you're so insulin resistant that your body struggles, and some women even get to a point where it's so bad that they actually need insulin. But there are so many different parameters and ideas about what it means when your circulating blood glucose numbers are actually too high. So some people say this number means it's too high. Some people say this number means it's too high. And it varies from nation to nation as well. So I don't really want to talk too much about numbers today because I feel like numbers are all over the place, like all over the place. And you could get, you can have even among providers who have the same governing bodies, they can say, well, in your case, I don't feel too worried about this. So, but so the ultimate reason why people are afraid of gestational diabetes, why providers are afraid of gestational diabetes. Do you want to take a guess of why providers are afraid of gestational diabetes?
I would
Sorry to
assume
put you
it
on
would
the spot.
be, no, I assume it would be probably a big baby.
Yeah, you got it, HeHe.
Yeah.
Nice work. I knew you would know. Yeah, so it ultimately all comes down to we're terrified, terrified of big babies. And why are we terrified of big babies?
Oh,
Because
shoulder dystocia,
yes, because
hemorrhage.
we're
We're
worried
just
about
like so
Mhm.
scared of them for no
Yes.
reason.
Yes, we're worried about shoulder dystocia primarily. Postpartum hemorrhage can rates can be higher with a distended belly, things like that. So yeah, so it ultimately comes down to that. So the history of gestational diabetes is that, you know, in the 1940s or so, people were starting to go, is this the thing? And the numbers back then in the 1940s, it was thought that 1 in every 2,000 women had gestational diabetes.
Wow.
Now it's like astronomically high. I think it's something like we're diagnosing 1 in 8 women with gestational diabetes. It's actually crazy.
Wow.
I might not have that number exactly right, but it's up there. It is way, way, way high. And a lot of people say, well, that's just because obviously in the 1940s we didn't have testing in place. And so now we're testing more often and we're catching more people. But that's research shows that that's not actually the case. We're not actually improving outcomes at all by making those thresholds lower and lower and lower and lower. Yeah, so that's what gestational diabetes is. It's insulin resistance to a point where a woman could be circulating so much glucose in her body that then the baby has to use their pancreas to take care of it. So a lot of people don't realize that. A lot of people think, oh yeah, it's high blood glucose numbers. What does that mean? It means that the baby now has to take over the job of dealing with those high glucose numbers because the mom doesn't have enough insulin to deal with that. Does that make sense? A lot of people don't realize that. So
It
that the
does make
baby's
sense.
pancreas is actually the one who is dealing with these high blood glucose numbers if a mom can't.
And what's the problem with that?
So a baby having to deal with high blood glucose numbers, if it can't use all that glucose, then it's going to store that glucose as fat, which is going to then create that big baby. Yeah. So we get worried about that.
One of the most shocking things that I found out in my early career as a doula was, I mean, shocking, was that you could have three different hospitals, and this hospital has a cutoff, and this hospital has a cutoff, and this
Mhm.
hospital has a cutoff. So you may not be gestational diabetic over here, but at these two, you are. And
Mhm.
so it literally could just be a matter of where you chose to have your baby
Mhm.
on what determines whether you have gestational diabetes or not. I mean, I was floored when I
Yeah.
found that out.
Yeah. Yeah. And it varies so much from nation to nation as well. And then the testing, this is interesting. The testing that we do in the United States is actually not recommended by any other governing body in the world.
Go
So
figure.
yeah. So the governing bodies around the world, you know, like the big ones, like NICE in the UK and Queensland in Australia, they recommend the 75-gram glucose test, where a mom fasts all night and then she gets her fasting numbers taken, and then she has the post or the 1 hour, the 2 hour, and the 3 hour.
Okay.
And that's the gold standard in the world. But in the United States, for some reason, we do the 50-gram load. I actually think both of them are terrible because, like you were talking about before, why would you put that into your body? You don't. Do you ever do that? HeHe, do you ever take in 50 grams of glucose or 75 grams of glucose at one time? Maybe if you go to your friend's birthday
I
party
was
and you
literally just thinking maybe at a birthday party. That's so funny.
Yeah, but that's like a celebration. If you're going to birthday parties 3 times a day, that's bad, you know? But if you're every once in a while indulging in a piece of cake, that does not reflect what your regular day-to-day eating pattern is. And so it for me in my practice, I mean, I was always taught, you know, to do the 50-gram glucose or the jelly beans like you were talking about before. And the 50-gram glucose, I saw so many false positives. And I feel like I also saw some false negatives with that test. And so I actually hate that test. First of all, I think it's kind of an assault on the system, the mother system and the baby system, to give them 50 grams of glucose when that's not what they normally do, when that doesn't reflect what the mom's normal diet is. I think that it can be really harmful. And I also think that it just doesn't really tell me what is a woman's body really doing with this glucose. What is her body using the glucose well, or does she have so much circulating glucose that her baby is then having to take care of the extra glucose.
So what is the point of challenging your body like that if that's not our normal sugar consumption?
I think that people just want to see if you have enough insulin to be able to take care of that, to take care of a huge load. And I have no idea why those numbers were put into place. I probably could have done some research on that to see why those numbers were put in place, but those numbers are considered like a high number, a large number amount of sugar. And maybe the numbers were put into place because people were like, hey, if we think of the most that a woman could ever eat, a giant piece of cake or something like that, then let's just see what this would look like. But the fact is, I don't know any women, even women with very poor diets, who are taking in that much glucose regularly at any one time. So it's probably just to like really, like you said, really challenge the body to see if it really has enough insulin to deal with a huge load of glucose. And then if it doesn't have enough insulin to deal with that, then we consider the woman to have gestational diabetes, because now her baby has to deal with that, has to use its pancreas to produce the insulin to deal with that.
That is the wildest thing to me. I guess like twofold. Why would we challenge your system when we already know that you're pregnant? Like that just is so crazy to me.
Yeah,
And
yeah.
why we wouldn't just look at your normal blood sugar over a period of time based on your particular diet, lifestyle, movement
Mhm.
routine.
Well, my thought, because I've wondered that many, many times before, because I'll share. I know we're going to talk about testing, but the way that I most love to test,
Yeah.
or uh, to know what's going on with a woman's blood sugar, is for her to test her numbers regularly over time while she's eating her regular diet. And I have, I encourage women to also keep a food diary so that they know what foods were they eating when they got these numbers, so they can go back and look, oh wow, when I eat this, my numbers are really pretty high, and I should maybe consume that in smaller amounts, or maybe eat it with protein or something. So
Right.
I love that method because I feel like it really helps women to know their bodies even more deeply. And as a midwife, that's part of my job, is to empower women to know their bodies even more deeply than they already do. So I love the method of either using a CGM, which, guess what? Well, you already know this because I think you
I
might
did it.
have used one. Yeah,
Yeah.
but they're available over the counter finally.
Yep.
And they used to be like $350, and now they're $99. So
Mine was 50.
that's
Mine was $49.
what? Are you
Yeah.
serious? That's
Yeah. So I
amazing.
used this is not sponsored by any means, and it wasn't when I did it on Instagram a couple of weeks ago. And I'll share a little bit when we get to CGMs about why I chose to do it. But I used Lingo, which is an
Mhm.
Abbott product, so a very reputable. They are a pharmaceutical, so you have to keep that in mind. They're a pharmaceutical
Yeah,
company, but they are
yeah.
a well-known, reputable pharmaceutical company, and they are not new to the diabetes space. And so they
Love that.
actually have a CGM that's marketed for non-diabetics because people are interested in their blood
Yes,
sugar. So
yes,
this CGM that they have is $49, and they specifically say this is for people who are not
yes.
on insulin. And I thought, how perfect. It literally
Yes.
is nothing but a basically a wearable wellness monitor. And that's exactly what I was going for. I just simply wanted information about my blood sugar.
Yes.
I didn't want anything else. And I found that the Lingo product was easy to use, comfortable, cheap enough. I mean, I loved my experience.
I love that. Can I ask you a question? Did you use it early in pregnancy?
I did. So I used it in weeks 13 physically pregnant, 15 on paper. And
Gotcha. Yeah. Hmm.
yeah, so I'll tell everybody why. Kind of going back to your false positive, false negative. So I figured before I got to the 28-week mark when we test for gestational diabetes, and I haven't decided how I'm going to do that personally. I'm not sure exactly yet, but I knew that if my blood sugar wasn't stable now, leaving the first trimester, going into the second trimester, that when I challenged my body, I would not be able to handle that. And so I wanted to see if what I was doing currently, leaving the first trimester, entering the second trimester, my food intake what I was eating, how
Mhm.
often I was eating, the pairs of food that I was eating together, plus my lifestyle
Yeah.
and my movement routine. Was it stabilizing my blood sugar and was it properly supporting my body to be able to handle the glucose when I ate, bring it back down to a stable level in a reasonable amount of time, and then keep it stable until the next time I ate? I'm very lucky that I found, yes, my body was doing exactly what it was. My numbers were perfect. They looked amazing. I worked with a nutritionist that was able to help me understand that. And for me, it was super insightful. I have never looked into blood sugar before. I didn't really know anything about blood sugar before. It's not anything that has ever been on my mind, but I knew that I wanted to, if there was any changes or accommodations that I needed to make before I
Mhm.
got to the 28-week mark, I wanted to do it now. And I wanted to give myself months to be able to do that so that if I decide to challenge my blood glucose with the glucola drink, that I'll be ready for it.
HeHe, we all know that you're not going to do that. We know you well
I'm not
enough.
taking the traditional glucola drink. Yes, that's right.
I know that you're still deciding on your methods, but I don't think I think I know you well enough. Okay, so here's something super, super interesting about
Okay.
that. Your insulin levels are actually pretty normal and pretty similar to what they are pre-pregnancy until around 20 weeks of pregnancy.
Okay.
And that's when you really start that insulin resistance because that's when your baby
Mm.
starts growing and needing more glucose.
Okay.
So bodies will normally start that insulin resistance more at around 20 weeks. And if you would have gotten poor numbers when you did it in early pregnancy, you would have been considered a diabetic person, not someone who has gestational diabetes. You would have been
Wow.
considered someone who is actually diabetic. So
Okay.
even outside of pregnancy is actually diabetic. So great, you're not diabetic. That's
I don't
amazing.
have
That's
diabetes.
wonderful. Yeah. And on that note, I should say that a lot of the research, almost all of the research that is done on gestational diabetes takes into consideration women who were diabetic before they got pregnant. And that is not fair because it's a completely different thing. Obviously, someone who's diabetic, the same mechanism is happening, where the baby's going to have to deal with some of that extra glucose. But that's women who are already diabetic coming into pregnancy, they have a whole different set of things that they're dealing with than women who become so insulin resistant that they become a gestational diabetic person after that 20-week mark.
Hmm.
So the research that we have that says that, well, we have a higher risk of stillbirth and we have a higher risk of this and we have a higher risk of this and this and this and this and this. It's not very accurate research because it doesn't take into consideration just those women who have become diabetic in pregnancy. And that's why we do that gestational diabetes testing later in pregnancy, because that insulin resistance really begins at about that 20-week mark and then starts, you'll see like our normal insulin levels kind of go like this and during pregnancy, and then at 20 weeks they sharply
Oh,
we sharply move to more insulin resistance, which is normal. That's what's
okay.
supposed to happen. And the reason why, I'll kind of say it again because I think it's really hard to understand the concept of why a baby could get big. Again, that happens because as a baby has more need for growth, they have more need for glucose, which helps them grow. So as that your baby's, before 20 weeks, it's little, still kind
Little
of little,
baby.
not putting on a ton of fat right now. And then as soon as you start that insulin resist, like as soon as your baby has that need for more growth and more glucose to accommodate that growth, the mother's insulin, that's normal physiology. The mother's insulin is supposed to reduce in order for her body to have higher circulating levels of glucose in order for her baby to use that glucose
And to get fat. You're
to
trying to
grow.
make your baby
Yes.
fat. Wow.
Yes. Yes. And here's another thing about babies getting fat. Babies are supposed to get fat. They're
Yeah.
supposed to get fat. I actually, okay, I told you I was going to tell you some super mind-blowing things in this podcast. I have to share one of those with you now about baby fat, and I'm going to read it just to make sure that I tell it to you correctly. But a baby between the 75th and the 95th percentile. Here, let me scroll to this. The risk of stillbirth is actually lowest in babies who are between the 75th and 95th percentile.
Wow.
So we think of like 50th percentile as being average, right? Like an average
Totally.
birth weight. So babies who are actually considered large for gestational age have less chance of stillbirth.
Why do you
And
think that is?
I personally think that it's because the babies have enough storage to deal with life, with extrauterine life and with intrauterine life. I think like tiny, skinny little babies, they struggle. They have a hard time with utilizing storage because they don't have any, so they have a harder time breathing. They have a harder time. Like we know that low birth weight babies often go to the NICU because they just don't have the strength to move on. So fat babies are actually, they do quite well. They do really well. But here's another thing about fat. So all babies lay down fat. They're supposed to lay down fat. And the way they lay down fat is by taking that extra glucose and using it to store it as fat on their bodies. An interesting thing to note, though, is that one risk factor that we do know is an actual risk factor for women who have uncontrolled gestational diabetes is that those babies will gain more fat in their shoulders, in their upper bodies. And so that gestational diabetes is a risk factor for shoulder dystocia. But when I say it's a risk factor, I mean gestational diabetes that is not controlled.
Hmm.
So we're talking about gestational diabetes is just the mom is like, maybe she hasn't had any prenatal care. She doesn't know she has gestational diabetes, and she's not eating a great diet and it's uncontrolled and she has no idea. Those babies so you could have like a 9-pound, 5-ounce baby here, born to a mother without gestational diabetes and or with gestational diabetes, but really well-controlled numbers. And then you could have a 9.5 pound or 9-pound, 5-ounce baby here, born to a mother who has gestational diabetes, but it wasn't well controlled. And this baby has a much higher risk of having a shoulder dystocia because of where it lays down that fat. So weight has nothing to do with it. It has a lot more to do with the distribution of that weight than it has to do with the weight of the baby.
Wow.
So
That's fascinating.
crazy.
Okay, so in controlled gestational diabetes, where do we see that fat disbursement happen on babies? In their
It's
belly?
just normal. It's very like regular in a
Oh,
woman who has gestational diabetes, but her numbers are well controlled. If she has well controlled glucose numbers, then she's not going to have an abundance of circulating glucose in her body that the baby then has to deal with.
got it.
So like let's say a mom doesn't have gestational diabetes and just eats super well, which so many women in America have access to plenty of food, and most of us have access to too much food. I do acknowledge that there are many people who don't have access to enough food, but because we live in a country where most people have access to an abundance of food, we see pretty fat babies in women who are eating really well. At our birth center, 1/4 of our babies are in the 9-pound range. One
Wow.
quarter of our babies. And most of those women have chosen to do gestational diabetes testing in some form and do not have gestational diabetes. If we have someone who has not well controlled gestational diabetes and like it's really bad and their numbers just cannot get in control, we send them to a diabetes clinic and often they end up needing to be in a hospital to give birth, right?
Okay.
Because those numbers are just out of control. So everyone who actually gives birth at the birth center, they either have well-controlled numbers if they do have gestational diabetes, or they don't have gestational diabetes. And we know that because we have done testing, and 1/4 of them are in the 9-pound range.
Big baby.
Now, yeah,
Healthy
yeah,
baby. Not a big baby that you should be scared of, though. So when I say like
yeah,
baby, I'm thinking like big, squishy, lovable, kiss those
yeah,
cheeks baby, not like, oh
yeah,
my God, we should be terrified of this baby. It does,
yeah,
though, mean get off your back. Do not
yes,
birth
yes.
on your back. Get
Move
up.
around.
Yes,
Yeah.
let your pelvis open up. Get that big 9-pound baby out of there, but
Mhm.
don't be scared of them.
Yeah. And midwives do deal with more shoulder dysocias, generally speaking, because we
Okay.
don't intubate people.
Okay.
And so we generally do have bigger babies than what they see in the hospital. But most of those babies just fly out. So, and we're really, really good at managing shoulder dystocia. Nobody wants that, right? Nobody wants that. But the best way to prevent a shoulder dystocia, okay, I'm going to give you another mind.
Mind blowing.
You ready for this? the two biggest risk factors for shoulder dystocia. It's not anything that you think it is. It's not eating too much. It's not even uncontrolled glucose numbers. That is not one of the two biggest risk factors.
Can I guess? I want to
Yes,
guess before you
I
do.
want you to. Yes.
Okay, so my guesses are birthing on your back and one-step delivery.
Oh, I love that. That one-step delivery, man. That
It's
definitely
horrible.
a lot of shoulder dystocias. Top two risk factors for shoulder dystocia. You made a guess. But do you want to hear what they really are? Your
Yeah.
guesses are fantastic, and absolutely those play a role.
Okay.
The provider believing that the baby's too big. So not a baby that's too big, a provider believing that a baby's too big. And so they increase what you just said, that one-step delivery, because they're terrified, right? So get the baby out, or have the mom lay on her back so we can manage in case we have a shoulder dystocia. So we apply all these interventions when we think there's a big baby. So that's one of the risk factors, provider believing that there's a big baby. And the second risk factor is induction.
Duh.
And what's the biggest reason why we do induction?
Big baby.
Yes, to
Oh my
prevent
gosh.
a big baby from happening. But induction actually increases the risk of shoulder dystocia. And there is good research to show that. Like anybody can refute that with me, and I got you. There is good research. And my thought, I don't know that anyone's really looked at why induction can increase the risk of shoulder dystocia. My thought is that, babies know how to come out. They know how to come out. And when you force them to come out, I think that maybe they're like a little confused, like, wait, is it time to rotate? Was I supposed to rotate? I'm not quite sure. Yeah. So that's kind of my thought for that.
Yeah.
But
My guess is that the overuse of Pitocin. So if you're part of the birth lounge, then you know this well, because I talk about it all the time. Literally every time I'm in the birth lounge, I speak about it. But your baby drops and they spin in this corkscrew movement. It's not just a drop. And they're not
yes,
spinning fast either. It's a nice,
yes,
subtle, gentle, gradual rotation. And I believe deep down in my heart, and one day I'll have the money to fund these studies, and I will. And I believe that with the overuse of Pitocin, we're actually causing those babies to rotate way too fast. And so by the time
yeah,
they get to be pushed out, I actually think that they are in this malpresenting place.
mm-hmm.
And
Yes.
I don't know that it's necessarily too far off from where they should be, but I think it's far off enough that it is harmful. And I
I
think
mean, it could be this, it
oh,
could be,
millimeters.
yeah, and that they
Centimeters.
didn't rotate, and then that can get them stuck on the shoulder. Yeah.
Totally. I think a
Or
lot of
on the
people do
pubic bone.
not realize that. And I think a lot of people, feel resistant to turning down Pitocin or turning off Pitocin or asking to titrate it down, not realizing that there's a ton of benefits of just letting your baby naturally descend in your pelvis, not only for you, but for your baby as well,
Yeah.
and the long-term health of both of you. Like, we must be mindful of Pitocin use, and it's something that I'll never get off of this pedestal. I will never, ever get off of this talking point ever.
I love that you said we need to be mindful of it, because you didn't say we need to never use Pitocin.
Oh
We
gosh, no.
need to be mindful when we're using Pitocin, because sometimes Pitocin can really be very beneficial, right? Sometimes it can be very beneficial, but the amount of times that we're using it, absolutely not. No way. No
And
way.
the
I live in,
levels that we're using.
yes, yes. Okay, I know that this talk is not about Pitocin, but I need to tell you something about this. In the olden days, when I first was a doula and worked so let's say a quarter of a century ago, it was not abnormal for Pitocin to be at a 2, start at a 2. Then we go by increments every hour of 2. So we go up in an hour to 4. And then we go up in an hour to 6. And what are we doing now? You see this. You've seen this at the hospital. We start at 4, 8, whatever, and then we go up by increments of 4 every half an hour.
Oh, even Q15 sometimes.
How high is the highest you've ever seen Pitocin?
28.
Oh my.
Absolutely horrible. The FDA clearly has recommendations against that, and the
Yeah.
mom was asking to turn it down, and the hospital refused. I mean, it was abusive. It was truly, truly abusive.
Yeah, I think the highest I've seen is around 30, so around the same as you've seen it. And those oxytocin receptors, they poop out after.
Totally.
You can't And I love that. I feel like some nurses are starting to go, we need to give you a break. But I still feel like sometimes I have a friend who's a labor and delivery nurse, and she's a traveling nurse. So she's seen it all. She's been to many states. And I love her because she told me that sometimes the doctors will be talking to her at home and they'll be like, just turn up the Pitocin, get this baby out. And she'll say, nope. And then like hang up, and she won't do it. And she doesn't get in trouble. She's just like, no, absolutely not. I'm not doing that just for your convenience. No. And which I love about her, but she has this, like, she's built herself up to have this notoriety where doctors are like, she's like super knowledgeable and we need her. So lucky her. But yeah, it's absolute insanity. Absolute insanity. So gestational diabetes, going back to risk factors, gestational diabetes is not even one of the risk factors for shoulder dystocia. We do know that that babies born to mothers who have uncontrolled blood glucose numbers, they do have higher risks of a chance for shoulder dystocia, but it's not one of those top 2 or even the top 3 reasons why we have shoulder dystocia. So yes, it can play into that, and it is a risk factor, but there actually hasn't been good research to link gestational diabetes with shoulder dystocia. We think that because babies make more fat here, that there probably is a higher risk of shoulder dystocia with babies born to mothers who are gestational diabetic. And so we list that among the risk factors, but there's not actually super good research to show that.
And I love the distinction that you made of controlled versus uncontrolled, because I feel like in the hospital system, that distinction is not always clear or presented or made a distinction of, right? And so a lot of times they're just like, well, gestational diabetes, you're lumped into this category. And we have a lot of clients who are knowledgeable enough to say, but my numbers are good and it's controlled and I'm not on insulin and I'm not having any trouble. So how come I'm having to have all these interventions? And it's hit or miss whether that provider is able to actually answer that question with an evidence-based reason or not, or whether they just say, well, it's our policy.
Yes. There is, if a mother has well-controlled blood glucose numbers, she's been diagnosed with gestational diabetes, which honestly, does she really have it? We don't know, because we have made those threshold numbers so low that the whole world has gestational diabetes now. You know what I mean? So even let's say it's someone who really truly has gestational diabetes, but she controls her numbers well, none of the risk factors, none of the things associated with gestational diabetes apply to her. None of the things. So she doesn't have a high risk of stillbirth. And every single woman who is diagnosed with gestational diabetes, they tell her the reason we're inducing you is because you have a higher risk for shoulder dystocia and a higher risk for stillbirth. There is zero research to show that if a woman keeps those numbers well controlled throughout pregnancy, that her risk for stillbirth or shoulder dystocia goes up.
Wow.
So I know, mind blowing, right? But nobody says that. Nobody says if your numbers are well controlled, then actually induction to prevent shoulder dystocia will actually raise your chances for shoulder dystocia.
Causes more harm.
Yes. It's just mind blowing to me that people say the reason you need this is to prevent stillbirth and shoulder dystocia. But we're actually causing a higher chance for shoulder dystocia. And we know that mothers do not have a higher risk of stillbirth. And there's actually some research to show that even women who have poorly controlled blood glucose numbers do not have a higher risk for stillbirth. And I'll send you the research and you can put it at the of your podcast.
Yeah.
So we're just terrifying women. And first of all, we're labeling exorbitant amounts of women as having gestational diabetes, and they don't. And then when those women have that, so we're increasing their medicine intake, so their drug intake is increased, their intervention rate is increased, and even in pregnancy is increased. So we're doing serial ultrasounds now, we're doing serial fetal heart checks, non-stress tests, right? We're having them come in every week instead of every 2 weeks. So we've increased the amount of money that we're throwing at this. and like insane amounts of money. One study actually showed $500,000 within this short period of time that was put into extra testing and extra drugs that could have been spent on, teaching people more about physiological birth, and it didn't improve outcomes. None of these things improved outcomes. The research is clear that none of these interventions and lowering the thresholds have not improved outcomes.
Yeah,
In fact, we've probably created more shoulder dysocias and issues with induction with these interventions. Yeah, crazy.
It
There's
really
also
is.
another mind-blowing thing I need to share with you. There's some question among researchers about what we're doing when we're restricting glucose to babies.
Okay.
So most babies, that if a mom truly has gestational diabetes and we're restricting that glucose in the form of, carbohydrates, or the mom's exercising well. So we've kind of put these interventions in place where the mom's moving her body and she's eating really well, right? When we have those interventions in place and we have these women who have these really good blood glucose numbers, she's going to have a baby probably who is a really good birth weight. But if she's restricting to the point where her baby's not able to lay down glucose, there's been some research that shows that it's actually dangerous for the woman. That there's actually an increased risk for preeclampsia. Like there's a huge list that I could read you. And then people are postulating that there could also be risks for the baby as well. So we're essentially restricting growth in a baby. So we induce people for intrauterine growth restriction, right? Because we're like, this baby's not getting food, it needs to come out. But when we tell people to control their numbers within these certain thresholds, we're also restricting blood glucose. So what if we're restricting blood glucose in a woman who has been labeled as having gestational diabetes, but she doesn't actually have gestational diabetes? Like, what are we doing? Are we growth restricting her baby? And that has implications for years to come.
But
And
we don't have any studies for that, right?
No, there hasn't.
Well,
Well,
actually, the data.
Let me find, there actually has been one review, and I'm going to read you because there actually is a list of things okay. I hope you don't mind me reading this because this is like, and I actually have to say, I learned so much about what I know about gestational diabetes through my own practice and experience, but also Dr. Rachel Reed and Dr. Sarah Whipham.
Yes, I love her too.
Yeah, those ladies on the research, they are, whoa. Okay, so a Cochrane review showed that there are ever varying numbers for what blood glucose thresholds should be, right? Like we're changing them all the time. I think our last time we changed them was in 2010. And it actually, one Cochrane review showed that more tightly controlled numbers, right? Meaning that we're like very much restricting glucose in a woman's body, like in the form of usually carbohydrates, which carbohydrates have such a bad rap. We need carbohydrates, especially when we're making a baby. We need carbohydrates. So one Cochrane review showed that the more tightly controlled the numbers that we force women to be into if they're labeled gestational diabetic, that there's actually a higher rate of maternal death, pulmonary edema, stroke, cardiac arrest, placental abruption, hemolysis, major postpartum preeclampsia, major postpartum hemorrhage, eclampsia, and deep vein thrombosis.
Wow.
The more tightly we restrict the numbers. A Cochrane review showed that, and I'll send you that as well. And then with the babies, they showed that, let's see. Okay, so neonatal adiposity, that means fat on a baby. If a baby has plenty of fat, we think it may be associated with better childhood insulin sensitivity, decreased adult cardiovascular disease, and that there also may be long-term benefits to a baby reaching their full birth weight. When we're restricting glucose in a woman, we're restricting a baby from reaching what the birth weight was supposed to be, right? And it can also, decreasing birth weights is also associated with an increase in adult all-cause mortality for the baby that we decrease the birth weight of, cardiovascular disease, stroke, and type 2 diabetes.
All things facing Americans like right now.
Yes. So there obviously is a fine line between like, if someone truly has gestational diabetes, and I have had about 5 people in my 10 years of practice who have had true gestational diabetes. Only one of them we couldn't get under control, and she had to be on insulin and work with a hospital provider. But she was also eating a lot of fudge. Her family owned a fudge shop. And things like that. So yeah, but all of the others we've been able to manage with diet and exercise. And I remember very specifically three of them all coming to me. We talk about, how was your week this week? How are your numbers this week? How is exercise and things like that? And every single one of them would say, the three that I can remember very specifically were like, I had some high numbers this week. I'm freaking out about it. And we know that a few high numbers every once in a while, based on these thresholds that someone just decided to come up with. And the thresholds, I know I'm talking in a big circle right now, but the thresholds were actually mostly based on preventing a big baby, not preventing any other complication, just preventing a big baby. So those numbers were based on reducing a baby's birth weight. So that goes back to what we were talking about before. But let's say that I give these women these thresholds and I say, I would like you to stay as close to these thresholds as possible. They would kind of freak out if every once in a while they came out of those thresholds. And they all had babies in about the 7 or 8 pound range. Like, they all did fantastically, and their babies all reached the birth weight that they were supposed to reach. And we did that by not restricting it so heavily that the mom's not stopped gaining weight and that her baby's not gaining weight anymore. The baby is still gaining well, but she's also like really watching those numbers, and she's aware, and she's being mindful about what she's eating, and she's being mindful about her movement. But I just think of all of the women who are in these clinics where they're like, you can hardly eat any carbohydrates at all. And we know that there are guidelines for people eating way too many carbohydrates for women who truly have gestational diabetes, and guidelines that are way, way, way too low for making a healthy baby. So there's a lot we still have to learn about gestational diabetes. But I always like to go back to, like, what is the woman feeling? What are the signs that we're seeing? How is the baby growing? How is the baby moving? What is her intuition telling her? And that's kind of like how I like to work with women who are dealing with these things.
Yeah, very individualized care. It's who's on my mind right now are all of my clients and my friends who are super healthy in they eat healthy, they have a healthy lifestyle, they have a healthy body and weight, and they got diagnosed with gestational diabetes, and they're shook up about it, and they're so caught off guard, and they're like, how did this happen? I didn't do anything to really cause this, and I don't have any signs and symptoms, and like, how did this happen? And to be honest, it's a big driver for me to wear the CGMs, because
Yeah.
I wanted to make sure that I was not going to be diagnosed with a false positive, because I don't consume that much sugar. Of course, my body's going to respond that way. I
Yeah.
would
Yeah.
expect my body. I also expect that if I did the glucola drink, I would probably have a headache and nausea and fatigue and some of these really horrible symptoms, because my body would be like, what the hell is all of this? Why did you do
Yes.
this? And for me, it's just not something I'm willing to do to my body or my baby.
Yeah. I love that. See, we knew you weren't going to do it.
I'm not doing that glucola drink. I haven't exactly decided
Yeah.
what I'm going to do. I will test. That's what I will say is
Yeah.
I do believe, for me personally, that it is important to test, because like you say, I wouldn't want to have uncontrolled GD,
Mm-hmm.
but the glucola drink, the traditional one, is just not for me.
Yeah. So let's talk about testing.
Yeah,
Because you want to talk
please.
about that. I love it. I love for women to know what's going on with their blood sugar.
Hmm.
It's the rates of actual gestational diabetes, even with the thresholds that we've created, are actually quite low in a woman who has a normal BMI. And that's a whole other thing. I don't love even using BMI, but like,
Yeah, me
who
either.
who feels, she feels like she's within her desired weight range and health range, maybe we should call it that, and doesn't have doesn't have any form of diabetes in her immediate family. And she's generally eating well. We know that the chances of her developing GDM are extremely low. Like someone like you, your chances are probably under 5%. So super, super, super low. But I think the important thing about learning to manage your numbers, I mean, there are so many reasons and so many factors at play when we talk about blood glucose. Like if I have women who are like, I'm nauseated all the time, and especially in early pregnancy, but sometimes even in later pregnancy, and almost always it's a blood sugar issue. I have headaches, almost always it's a blood sugar issue. I can't sleep, almost always it's a blood sugar issue. So blood sugar plays a huge role in every system of our body. So I think it's really, really important for a woman to know what's going on with her blood glucose levels. That said, I have many women who decline testing, and I'm completely fine with that because they are taking responsibility for their health. And I also don't accept clients who aren't willing to take responsibility for their health or to take good care of themselves. If someone comes to me and they're like, I want you to save me, I'm like, I'm not the midwife for you. I don't save people from their choices, right? But I do think I love it when, let's say, almost all my clients, 96% of my clients are low risk, right? Super low risk for gestational diabetes. But I still love it when they're willing to either do a CGM, so continuous glucose monitor, which you put on the back of your arm, or to do finger pokes 4 times a day for 5 to 7-ish days, eating their normal diet, even indulging in a treat every once in a while if that's what they do. Yeah, just to kind of see like, what are these numbers looking like? And if her numbers look really good, then she can know that what she's been doing has been working well for her, and that maybe she needs to eat more often, or maybe she needs to eat more protein. So it can be very empowering to learn that about the body. That said, I do have some clients who want to do the glucola. They're like, I don't have time for that. I don't want to do it. I have not been eating as well this pregnancy as I hoped I would, because this is my 6th pregnancy and I'm taking care of all these other kids, plus this and this and this. And so they just opt for that. And I completely 100% respect that.
Totally.
And then I have other women who want to do the fresh test. And the fresh test, the only difference between the fresh test or say like a dextrose powder, which is molecularly the same as glucose. So we have dextrose powder because we just have a giant thing of it. We just do 50 grams in water. The only difference between those two choices, those powder forms, and the other form is that they don't have the preservatives in them. Yeah. So it's still 50 grams of glucose, right? So I still don't love it. And then we have, like you said, some midwives will do, I've heard of people, even hospital providers, I've heard of them doing like a naked juice drink or jelly beans or like the big breakfast. My issue with all of those, first of all, naked is fructose. It's not glucose, and it reacts differently in the body.
Okay.
And so it's not very accurate. I know a lot of midwives who are going to be like, wait, what? It doesn't represent glucose.
Because they're different types of sugar.
Yes,
that's the clarification, right?
Yes. And babies use glucose, and they do use glucose from fruit. So a baby can convert, the body will convert fructose to usable glucose, but it doesn't equate 50 grams of glucose. So the naked drinks don't work. The jelly beans work because they are glucose. They're straight sugar. They're not fruit sugar. They are straight sugar. But you have to eat 63 jelly beans. And it depends on what kind of jelly beans. So some people listening might say, well, in my practice, it's only this many jelly beans. That's specifically Jelly Bellies. 63 Jelly Bellies has about 50 grams of glucose, and probably different flavors have different levels anyway. So it's about 63. And I've had a couple people.
With that brand, you're also getting food dyes and preservatives and a lot of yucky things that a lot of people have strong feelings about.
I haven't had anyone do the jelly beans for probably like 8 years. But I remember I had a client doing the jelly beans, and she came in and she was like, I thought I was going to like this. But when I was on like number 43, she looked down and she thought, oh my gosh, I still have 44, 45. She still had a lot of jelly beans left. So, so I don't love the jelly beans either. And then the midwife's huge breakfast, great. Except for, is that how you eat normally? Do you normally eat a big giant breakfast like that? I hope a lot of pregnant women eat a big giant breakfast, but is it that exact thing that your midwife told you to eat? So my preferred way is doing the pokes or the CGM. The CGM, there is some research to show that the CGM, both methods actually, that they're a little bit off, that they're a few points off. So
Oh,
you're not always getting your exact number with your CGM or your pokes, but it's as close as we can get. It's as close as we can possibly get. And sometimes the CGM and the pokes will not show the circulating blood glucose of what it was 5 minutes ago or 5 minutes later. Like sometimes it'll be this random weird number in the middle, and then you're like, oh, that number looks great. And then 5 minutes later, it's like super high. But it's the most accurate, those are the most accurate ways we have of testing blood sugar, besides doing like an actual blood draw, which we're not going to do that 4 times a day. And so those are my preferred way. And I love it when people are willing to do that. I think the reason why we don't have those as standard care is because, first of all, CGMs are $1 million. No insurances are going to pay for those yet. Hopefully
yes.
someday they will.
Hopefully soon.
Yeah. And then many people are uninsured, so they can't afford that anyway. The poking the finger with the little glucose monitors that you can get from any drugstore for like $25. You can get them on Amazon, anywhere. That's the cheapest way, I feel like, to do things besides the glucola. But it's also, you have to poke yourself. And some women are like, the sight of blood, there's no way I can do this. There is no way I can do this. And so then another method might work better for them, like the fresh test or a dextrose solution.
Yeah.
But yeah, so my preferred what I think is the most accurate is doing the pokes and the CGM. But I don't think that any governing body is going to say, okay, now our preferred method is having women poke themselves 4 times a day for a week. Because there are many women who aren't going to do that. Many, many, many women who will be like, absolutely not. And I also think that, we talk a lot about trusting women, but I think that most organizations don't trust women.
Oh, not at all.
So they're not gonna trust women to self-report these things. They're gonna believe that women are lying to them when they report what their numbers are. So I think that it would be a preferred method if, first of all, it didn't involve drawing blood on yourself, which is really hard for some women, and also self-reporting. So I think that's why we do the glucola. I think that's why we do that. And I don't know why we have to put all that crap in there, you know.
Yeah. So just to kind of summarize what we have talked about so far in terms of testing, we've got some kind of untested, possibly unreliable methods. The jelly beans, the big breakfast, the naked drink, right? These are things that are used for sure. You'll find them, but they are not truly proven. And then we've got two really good options. You've got the challenge test, which you've got some options there, traditional glucola, fresh test, or the dextrose powder that you mentioned. And that is challenging your blood sugar. You want to see a big spike, you want to see your body come down and manage that with insulin production and then stabilize your blood sugar. And then the second option, which arguably you're saying is more reliable, I also tend to believe it's more reliable as well because it is in real time based on your routine is going to be blood sugar check. So you can do that via your finger multiple times a day, or you can just wear a continuous glucose monitor for what you said was 5 to 7 days, right? And
I think most
kind of,
continuous, yeah, I'm so sorry. I think most continuous glucose monitors are meant to last for about 2 weeks.
yes.
So I have had some people wear them and they don't like the comfort. And so they've taken them off after a week or so.
Okay.
But I think that you can get a really good idea, unless you're on vacation and you're not eating your normal diet or something. I think you can get a really good idea of what your normal diet is doing to your blood glucose, circulating blood glucose in a week. I think a week of that is perfectly fine.
Yeah. So
You're not
that's
going to
what I
vary
did.
your diet.
Yeah,
Yeah.
that's what I did
Yeah.
when I wore the lingo. And like I say, the nutritionist I worked with was super happy, and she was just like, "These numbers are amazing, and it looks like you're eating plenty of protein. It looks like you're pairing your protein and your carbs really well. And when you have sugar, I mean, because I don't live a sugarless life. I don't want anyone to
Yeah.
think I, like never have a chocolate chip cookie,
Neither do I, HeHe, and
you
people
know?
think I do, and I don't.
I love ice cream. I mean, it's one of my favorite
Same.
treats. I
We
love
need to
ice
get together and
cream.
eat ice cream.
Yeah, absolutely. An ice cream vacation. I just wanted to know that my body was able to respond to it appropriately. And now that you've mentioned the 20-week mark, I'm inclined to do it again around 20, 22 weeks and
Yeah,
then
I love that.
28 weeks and just
I
kind
love
of
that.
see. And that way, I also have multiple data points on my body and what my body is doing. And if there's any
Yes.
sort of trending patterns, I can stay ahead of it and I don't have to be caught off guard at the 28
Mhm.
week mark.
Yeah. And the fact that you don't have any issues with your blood sugar right now,
Yeah.
you're obviously that means that you're at lower risk for having blood sugar issues later.
Well,
I forgot about something we need to talk about
okay.
because a lot of people don't want to do any glucose testing at all. They want to do the HbA1c. And
Oh,
so I think it's really important for us to talk about that.
definitely.
So a lot of people are like, no, I'm refusing glucose testing. I'm just going to do the HbA1c at 28 weeks or at the normal time when we would do glucose testing. Have
Now,
you ever
what
heard
is
of the
that?
HbA1c?
I have,
So
but I'm not familiar with it.
it's a test that tests how much glucose you have attached to hemoglobin. So your hemoglobin are red blood cells,
Mhm.
and it's called glycation, and everybody does it. We all have glycated hemoglobin in our bodies. When you have an abundance of glucose circulating in your body that you're not using well or that your insulin isn't taking care of, you'll have more glucose attached to your red blood cells. So it's called glycated hemoglobin. So it's called glycation. It's a process that happens to all of us. So HbA1c measures how much glycated hemoglobin you have in your blood system for the last 6 to 8 weeks. So it doesn't work for gestational diabetes because it doesn't give us an accurate picture of what's happening to your actual circulating blood glucose. And here's the reason why. When you have that blood volume increase, you also have red blood cell increase. Every woman has a huge blood volume increase in pregnancy, right? Starting around 10 weeks, but really ramping up around 23, 24, 25 weeks, right? So you have this huge production of more blood, more red blood cells, more hemoglobin. So you have all these new red blood cells that haven't had a chance for glycation. So we don't know. So you might get an HbA1c test and it says, oh, this looks fantastic. But you might have high levels of circulating glucose that haven't had a chance to attach to glycate to those hemoglobin, those red blood cells. So if you are going to do an HbA1c, you should do it in very early pregnancy because then it can tell you what has been happening preconception. And preconception is really what tells you what your numbers are doing, and it can tell you that you don't have diabetes. It cannot tell you that you have gestational diabetes, though. It
Hmm.
can't. So it can be a nice test for maybe someone who has, like, all their sisters have had diabetes type 1, their mother had type 1, and maybe they just want to make sure that they don't have diabetes coming into pregnancy. It can be a nice test. But you want to hear something crazy? The threshold levels for an HbA1c in early pregnancy are lower than what an HbA1c normal level is like in pre-pregnancy. And an HbA1c is looking at your numbers 6 to 8 weeks previous. So if you get pregnant and it's reflecting what your numbers were before pregnancy, and those numbers are normal for pre-pregnancy, but they're not normal for pregnancy, they're going to say you have diabetes. So it's not fair. All of the numbers are lower. Every number is lower than what a person outside of pregnancy could be considered when when they have diabetes. So someone outside of pregnancy who has diabetes, their numbers can be here and they're not considered to have diabetes. And when you get pregnant, your numbers can't be above, it lowers, which isn't fair, but that's how it is.
Oh my God.
Yeah, so HbA1c, not a good indicator of gestational diabetes.
That's really good to know. I gotta say, I've heard about it, but like I say, I'm not familiar. I think because I just don't have any clients that ever opt for that. I know we don't want to harp on numbers, but I do think it would be helpful for people to know what the numbers are that we're looking for. So in terms of like ACNM or ACOG or NICE or ARCOG,
Yeah.
what numbers are we?
So most people say numbers, well, and you'll get numbers in different measurements as well. So I only know the numbers that we do here in the United States.
Okay.
So most people say, and Lily Nichols is a really good source for this as well.
Love her.
She's a really good source for knowing what your number should be. She has 2 really great books, right? Well,
Yes.
she has more than 2, but specific to pregnancy, she has 2 really good books. And I give every one of my moms that we think may have gestational diabetes, again, not that many, I give them that book and say, please read it. Yeah. So I believe that she says fasting number should be 90 or below. So that means right upon waking. And that postprandial, that means 1 to 2 hours after eating, should be 120 or below. Although in the olden days, they used to say 140 or below for postprandial. And most of my clients are within that range easily if they're eating a healthy diet, even with carbs. But if somebody was more in the like 150s and it was constant, then I'd be like, this is actual uncontrolled gestational diabetes. Yeah. So I hope that helps. I hope those numbers help.
Yeah, absolutely. And just keeping in mind that they are that cutoff is different based on what hospital you're at, where you are, what your provider's preferences are, hospital policy, things like that.
Yeah, and every once in a while, and even Lily talks about this, people get high numbers sometimes. Sometimes people have a 139 after a meal. And it's okay to have a high number every once in a while. It doesn't mean that you're going to make the hugest baby ever.
Okay, we've done a lot of talking about diet and food, and you even had acknowledged that food deserts are a thing. Even healthcare deserts are a thing in the US, unfortunately. So we do have some pockets where, a lot of pockets actually, where access to food and healthcare are lacking. But at the beginning of the episode, you mentioned that our numbers today are much more high and concerning than what they used to be. Do you think that this has to do with our sedentary lifestyle and our changes in our diet and our food consumption?
Yeah, absolutely. Yes. Yeah, absolutely. I think it's interesting to me because I have a lot of people who, a lot of clients who are like, I'm eating super, super well. And then, we'll look at the food diary and I'm like, that is
Not super well.
yeah, that's not what we thought it was. And to be fair, it is really difficult for people to find good food. I mean, even food that we think is healthy is often not healthy. So yeah, so it's really hard and it takes a lot of education and awareness. And most people don't have time for that. They just need to go to the grocery store and get the food and they need to
Be able to eat.
eat. Yeah, yeah, yeah.
So
So yeah, I absolutely agree with that. And I work with a population of people who have access to food and they eat quite well. And so I am sure that outside of my population, in the general population, I am positive that people absolutely eat more poorly, generally speaking, than most of my clients. And so that's probably why I see pretty good numbers. And I bet some people have really bad numbers.
Yeah, I think that's going to vary across the nation as well. I mean, I live in Boston
Absolutely.
now, but I'm from Mississippi. And so when I go home, the brands that I eat up north are not even available. They're nowhere to
Yes.
be found in the stores. And, their organic section is
Yeah.
just kind of minuscule. It's
Yeah.
one aisle, if that, where up north we
Yeah.
literally have whole stores of organic foods. And so, depending on where you live in the US, it can definitely impact that. Okay, my last question is, when we have a mom that has gestational diabetes, what kind of things are we looking for in that baby postpartum? Because oftentimes we have providers that will say things like, well, we're worried about your baby being able to regulate their blood sugar. Is that a true concern? And are there other kind of risk factors that will follow our baby if we have gestational diabetes?
Yeah, there hasn't been a ton of good research on what happens with uncontrolled numbers, but we do know that those babies are generally speaking at higher risk for metabolic disease, more higher BMI, issues with weight gain in their teenage years, things like that. But immediately postpartum, big babies of all kinds, even those born to mothers who don't have gestational diabetes,
Oh,
they need food. They need food. But specifically with gestational diabetic babies, they do need to be fed often. And hopefully it's with colostrum. So yeah, and so they can tend to be jittery and have low blood sugar because their bodies are used to dealing with this huge amount of glucose that they've been dealing with, and suddenly they're not dealing with that glucose anymore, and so they can have a tank in blood sugar. And so yeah, it is important to feed those babies often. They can also have something called polycythemia. So that's just where they have extra red blood cells, and they do have a higher risk for jaundice as well. But usually normal physiologic jaundice because of that higher rate of red blood cells. Yeah.
And for that, you would just do sun exposure and breastfeeding.
If it's normal physiologic jaundice, yeah, sun exposure and breastfeeding are the very, very best. I think I've only had 2 clients in 10 years who have ever actually needed to go and get on lights. And that's like astronomically low compared to how many people they say need to be on lights. So there, I mean, in the general population, part of it is because of the way that we treat birth in a normal physiological way. But the other reason is because it goes back to, you know, the same exact thing of just having these numbers that are like, oh, we have to be so careful. And I've had people who will tell me what their baby's number is, or, you know, like a doula client will text me or something. And you look at, you know, the chart and their baby's, the chart says, you know, that's from like the governing body says this baby should be breastfed and sun exposure, and they're still keeping them at the hospital. And that all has to do with litigation and things like that.
And money, it can all be traced back.
Yes.
I hate to be the pessimist that says follow the money, but when you do follow the dollar, it's always there. You always find there for sure.
Yeah, on that note, I've had a couple NICU nurses come to me, and they both told me that when they worked as NICU nurses that they were told, like, we need to keep these beds full. These beds need to be full. And to be fair, you know, birth is the biggest moneymaker in any hospital, right? The maternity ward is 80% of most hospitals' revenue, and the NICU obviously is part of that 80%, right? So got to keep those babies in the NICU. I would say like 80% of my babies would have been taken to the NICU. 80% of the babies born to me would have been taken to the NICU had they been born in a hospital.
Under phototherapy.
Or just for any reason, any reason. Oh, your baby's just not like transitioning in the way that we wanted them to. So in 10 years, I've had 2 babies go to the NICU that have been born at the birth center, and then they needed to go to the NICU. 2 babies in 10 years.
Yeah.
That's an astronomically low number.
Yeah, but also probably right on track with the true numbers if we treated birth as a truly healthy physiological process that we didn't intervene in unnecessarily.
Yes, absolutely. Yes. I mean, yeah, we let people go to full term. Their babies are born. I shouldn't say we let. That sounds so terrible. We encourage and support people in going to full term.
Oh my gosh, Melissa, I could honestly talk to you for days, weeks, years. I feel like we just have
so we could talk forever. Yeah, we really could
talk forever. This has been amazing. Is there anything else with the GDM that we haven't covered that you feel like people should know that I haven't asked about?
Let me see. I'm going to look at my list and see if I have any of those like mind-blowing stats that I want to share with you. I think we shared most of them. Yeah. Let's see. Yeah, I think we shared them all.
I love that.
Yeah.
Okay, well, tell us where people can connect with you and learn from you and be educated from you, both consumers of healthcare, but also doulas.
So I have a really great newsletter that I send out regularly, and it has such good stuff in it. I love the newsletter. I've got a lot of PDFs and graphs and things in there that help people to explain like things like VBAC and things like that.
Yep.
So, and people can sign up for my newsletter on my website, which we can put the link below. And then my daughter, who's also a midwife, we just launched a YouTube channel. It's so fun. It's called The Midwife and Her Daughter. And we chronicle our lives as midwives, and it's really fun. And lots of birth videos on there of us attending births. And then I also, I work a lot with doulas, as you know. So I have a really cool doula retreat coming up, and I have postpartum doula trainings that are just absolutely magical, and birth doula trainings and advanced doula trainings, and some are in person and some are online. And I just launched a business for doulas class. Let's do a discount for your people. If any
I love that.
If any doulas are listening, we'll give them a HeHe code. We'll give them a Tranquility by HeHe code so they can get 25% off. Let's do that.
Cool. And I'll link that for you guys in the show notes. And I just have to put a little plug in here that I've taken one of Melissa's trainings. Our whole team has, and we found it phenomenal. And we've all been doulas for several years. And, I always go into trainings wondering if I'm going to learn anything after 10 years. And it's kind of hit or miss. But I can say that in your training, Melissa, I walked away being like, wow, that was so beneficial. I'm so glad that we did that.
I
And
have goosebumps.
so,
Thank you, HeHe. I
yeah,
love that.
absolutely. So if you're a doula out there, listening, then and you're looking for some continuing ed and you're looking to kind of deepen your skills and your knowledge and your confidence, I can't recommend Melissa's courses any more than I do.
Oh my,
All right, you guys.
you're so sweet.
Absolutely. All right, you guys, I will see you in the next episode. Be sure to follow Melissa on social media, and you can find me at Tranquility by HeHe and at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.